This at the close of the conference, AIDS 2014 in Melbourne, and I'm talking to Daniel Reeders, who is an educator and a researcher in, particularly has a magnificent blog called Bad Blood, and it's specifically related to public health and stigma. Daniel, what have you got to say about public health and stigma?
Well, public health spends a lot of time talking about stigma as something else, as something that other people do and that public health has a role to play in reducing. Public health spends not that much time at all talking about its own role in maintaining stigma and reproducing stigma and creating new forms of stigma. So that's kind of really what I'm interested in. As a researcher broadly working within the field of critical public health. People often say, oh, I'm always finding fault or finding problems with public health, and I should instead be promoting public health. But I think it's really important that we're aware of the work that we do and the own goals that we sometimes produce in creating those stigmas that we are attributing to other people.
Quite an important event happened yesterday from Queensland. The minister, the health minister in Queensland, has hooked up with British Columbia for their treatment as prevention program. And one of the implied criticisms that was floating around yesterday from this is that it's going to be applied as a very top-down kind of model, which is going to bully people into having to take medication, and will stigmatise people who are not on meds, and particularly if they don't want to take meds. There is something important about public health approach, that it is possibly better than criminalising HIV. But it can be aggressive, can't it?
Yep. So we're here at the International AIDS Conference, and I've seen a couple of presentations that bear really directly on what's at risk when you take that top-down approach and you put pressure on people to start treatment in the public interest. And one of them was by an HIV treating physician and scientist here in Melbourne, Dr. Edwina Wright, and she argued that doctors should, when they're faced with a decision either in the interests of their patient or in the interests of public health, they really need to put the interests of the patient first. And that at the moment, the weight of the evidence, she said, doesn't actually favour starting treatment earlier than current recommendations in terms of the outcomes that are produced for individual patients. So she raised that as kind of a very important ethical issue, but also practical issue, that if you start treatment before you're ready, then you're at risk of having lower adherence to first-line treatment. And first line is the best line that there is. First line has the lowest side effects and the greatest activity. And if you start before you're ready, before you've done that hard work of figuring out what your diagnosis means for you now and what your motivations are to continue on treatment and to be adherent to treatment, then you risk blowing that first best option for living long without side effects from HIV treatments. Some of those side effects from later lines of treatment are quite serious. So I really feel that kind of as an ethical and a practical issue, we may at some point in the future be ready to recommend early treatment, but that time has not yet arrived. That's the first one. The second bit of evidence that we heard at this conference was from studies of PrEP, so pre-exposure prophylaxis. That's HIV negative people taking HIV drugs to prevent infection. And the evidence from a number of studies has shown that adherence is highest among people who were taking the most sexual risk. And to me, that really confirms that you can actually trust in this case gay men, to do what's in their best interests, to be adherent when they have those internal motivations, which can include altruism, and that the danger that we face in taking that top-down approach, recommending early treatment, is that you replace those internal motivations with compliance with some external source of pressure.
Coercion hasn't proven to be valuable. Coercion is not inclusive. It's not persuasive. From the pre-conference, the Beyond Blame one, I did register, and I can't think what it was, that you made a comment about what happens when public health and criminal law combine. What was that?
I've been working around those two issues of public health stigma and criminalisation since about 2006, and that was when the Michael Neal trial happened, and a whole bunch of HIV prevention people kind of suddenly sat up and took notice that we have this criminal law on the books. It hasn't been prosecuted before. We probably wrongly assumed that it wouldn't. But as a result of Michael Neal and an overly broad search warrant, a whole bunch of people were prosecuted for behaviour around HIV transmission or exposure. The discussion always troubled me because it constantly presented a kind of choice that we were being asked to make between a public health approach and a criminal law approach. And it rarely considered the way those two things actually interlock with each other, the way they work in combination with each other. So, for instance, there was an African migrant, a refugee man in Geelong, who was placed under public health detention, who had to engage with a counsellor, and as part of that process had to disclose that he'd had unprotected sex with women he'd met at nightclubs in order to demonstrate that he was making progress in counselling and to be allowed out of public health detention. But what that did is create records that could then be used as evidence in a criminal trial against him. And he had no immunity against those records being disclosed. As a result, he pled guilty to get a lower sentence. And we see this time and time again. These are laws that are very difficult to prosecute. If he'd gone to a trial, he would have had a better chance of getting off. But instead, because of the interaction of the public health and the criminal law, he effectively lost the ability to plead not guilty. So that's a kind of really practical example of it. It's a kind of higher level example is the way that if you're being managed under that public health process, the public health decision makers can decide that you're not making enough progress and refer your case to the police. So the principle in the public health process is that you use the least punitive measures available to you, which makes it sound all very soft and lovely, but people being managed under that process would be fully aware that if they don't behave in the way that process expects them to, then either they will escalate through that process or potentially they will be referred for investigation and prosecution. So we really need to think about the way the criminal prosecution and the threat of public health detention make a kind of infect that process of counselling that occurs in the very early stages.
Look, one of the things that does worry me, I mean, it's very clear that criminalisation is very discretionary. My feeling is that public health is even more discretionary and that perhaps even more vague, that there are more people with less information and less authority and qualification making important decisions affecting POS guys' lives. POS people's lives. I just have this feeling that shifting the balance to public health needs to be done really cautiously.
The balance already favours public health, though. We've seen vanishingly few criminal prosecutions for HIV transmission among gay men, and for a really arbitrary reason. It's that if you are a gay man diagnosed with HIV, the odds are it happens with a gay-friendly doctor who says, I will treat you myself, we will deal with this together, and makes referrals to community organisations for education, support, counselling, so that even though that diagnosis is a horrible experience, that person feels supported through that experience, and they don't experience it as this unprecedented rupture the way that someone who is heterosexual, diagnosed by a doctor who has maybe made one or two other diagnoses in his or her entire career, who probably doesn't know that there are community organisations for them, and who goes to the police instead of to a counsellor. That's kind of the key factor, I think, in why we see so few criminal prosecutions coming out of the gay community and so many coming out of heterosexual encounters. The thing I think that's important to note about the public health system is that it's a very new approach compared to criminal law. There are protections for defendants in criminal trials that date back to the Magna Carta, but public health has existed as a discipline for less than 200 years. The ethics and the principles that inform decision-making in public health are much less well developed. And as a result, there's a real variability in how it gets exercised. I have, in my own state in Victoria, a fair bit of confidence in the people who carry out the public health management process, although I certainly have criticisms about the philosophy of that approach. But I know that in many states around Australia, if you talk about unprotected sex to a doctor or a counsellor, the response is very much one of risk management. It's, if transmission results here, I could be liable, so I'm going to be very cautious, and regardless of the cost to my individual patient, I'm going to refer them to be surveilled and scrutinised and managed under this public health process.
It sounds good on paper. It wasn't nice for me. I think particularly with me that the real difficulty was around having an undetectable viral load, and I was just thinking, well, you know, what the fuck, basically. How the science is all stacked on my side, basically. And in fact, this is a really significant thing too. And what's just happened in Queensland with PrEP is, you know, they're treating it as a limited resource. This is another odd thing as well. Just treating treatment as a limited resource. Yep. So they're looking at PrEP and they're saying, well, who can have access to PrEP? And in a serodiscordant couple, this is what I understand, is that if the positive partner has an undetectable viral load, PrEP will not be available for the negative partner. So what that's actually implying, without stating it, is that undetectability is perfect. It's good. You know, there's no risk of transmission. Yep. So what I wonder from that, if that's actually known, why hasn't the public health response in Queensland made that clear to the community? Yeah. And why are they surveilling people with undetectable viral loads?
Yeah. I find that politicians place far too much trust in doctors. They assume that doctors think with a kind of hive mind, so that the minute one doctor learns about the science of HIV transmission, then it's magically transmitted to every other doctor in the state. As a result, we don't invest in engaging with doctors all across Queensland or all across Australia with messages about what gay men know about how to protect themselves and their partners, with what new HIV science is telling us about the risk of infection when viral load is undetectable. As a result, it's entirely possible, and without any way of knowing, you can go to a clinician whose understanding of the epidemic is informed by morality as much as by scientific evidence, and as a result, you can be referred for public health management when your viral load is undetectable and when you are using risk reduction strategies by someone who's had a kind of instinctive moral gut reaction and who is uninformed about the science of the risk involved in that practice.
So even under any circumstances, really, it does come down to this really nuanced interaction between the positive person and the very personal things that are going on, and of course there's no control with what is actually happening with the very personal things and that other healthcare provider.
And you're doing that in the context of a 6-minute appointment, potentially, in a publicly funded, publicly defunded, probably, health service.
And not everyone in public health wants to be co-opted in this way.
No. Public health is an extremely diverse field. I describe my work as public health, but I wear many different hats. Sometimes I'm community health, sometimes I'm health promotion, sometimes I'm the earlier discipline of health education. All of this kind of, however, gets captured by a philosophy of public health as a strategy of governance, as a way of inducing people to behave in ways that minimise risk and that maximise health by scrutinising their own behaviour. And if they won't do it, then there's a whole kind of armamentarium of clinicians and counsellors who are recruited into that project of making sure people behave responsibly with regard to risk. The alternative to a public health approach is a community health approach, and a community health approach says, let's use the diversity of experiences and knowledge within the room to have a conversation so that we each understand our different perspectives and that you can learn from things that other people do that have worked. And that can happen in a peer education workshop, or it can happen over a beer. It doesn't have to involve a doctor or a counsellor. My role when I'm working in health promotion, though, is to come along to conferences like the International AIDS Conference, to meet with doctors, to meet with researchers, to learn what I can from that scientific approach, and to translate that into resources that that community of gay men engaged in living with HIV, whether they're positive or negative, to create resources they can use to have those conversations and to support each other in preventing infection and supporting people living with HIV.
Look, a couple of really curious things have happened at the conference, though. Online, from a gay guy on social networking, he just, without recognising that I was Australian, but when he heard that I was at the conference, he said, "I hope you get your hole closed while you're here." And then, of course, there was this person who suggested that white middle-class privileged males who are on PrEP are taking valuable resources away from other people who can't afford stuff. There's plenty of stigma around all over the place. What, have you got any staggering examples of public health stigmatisation in Australia?
There have been a few in Australia and the global context where clinicians in particular don't understand that coercion and threats and fear are not a great way to motivate healthy behaviour. So they've been critical of gay men's health for not being, as they see it, tough enough. And so they've advocated first privately with educators to take a tougher stance. And when we haven't, both in Melbourne and in New York, we've seen clinicians stage press conferences or issue press releases saying there's a new strain of an STI and it's going to do really nasty things to you, or it's harder to treat than before. In the New York patients, we saw claims of a super strain of HIV that had been created because he'd had sex while on crystal methamphetamines, and there was extensive drug resistance transmitted. And all of those cases have been debunked. We haven't seen a super strain of HIV spreading because that's just not how it works. But what it does is it attracts enormous media coverage, and the message of that coverage is always that gay men are irresponsible, that gay men's educators are not taking a tough enough line, and that what we really need is doctors, and if that fails, a criminal response to motivate gay men to behave as kind of the good gay citizens that the public wants them to be. And it really misses the fact that we are already highly altruistic, highly informed, have a really strong sense of agency around these issues. And that's why the HIV epidemic is, in developed countries, not greater than it is, than it could be.
So I think that's a very good point for us to wrap on. And I want to thank Daniel for these really wise thoughts that we all should be thinking over sooner rather than later. So from the 2014 conference, goodbye.